Nice. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back, everybody. Thank you for sticking it out with us. My name is Bala Shipel. I'm a medical student at the University of Toronto. Here to introduce our next speaker, Dr. Zainab Furqan. So just a heads up, this session is geared towards mental health professionals. And if you're in a crisis, please reach out to the Canadian Crisis Hotline, toll free. I'll paste the number in the chat. Or you can visit talksuicide.ca. If it's an emergency, you can call 911. We also have a crisis psychotherapist who attendees can connect with if there's urgent need for that today to help navigate with supports. And you can reach out via chat privately to hosts and panelists if this is needed. Just a reminder, speakers are happy to answer your questions during the Q&A period. So please post your questions in the Q&A as opposed to the chat. And without further ado, I'm going to introduce Dr. Furqan. Her session is titled Suicide and Self-Harm, Evidence-Based Safety Assessments and Tools. Dr. Furqan is a clinical researcher at the University Health Network, where she works with diverse patients seeking psychiatric care. She's passionate about culturally safe care and understanding the mental health needs of Muslim communities in Canada. Her work has been published in major global and Canadian academic journals. So please help me welcome Dr. Furqan to the virtual stage.
Assalamu alaikum, everyone. It is such a pleasure to be here. Jazakumullah khair for all the organizers and the hard work that they have put into this conference. Please send them a note of thank you, make dua for them. I am quite aware of how many evenings and weekends they have spent on this conference. Like it was mentioned, I work as a psychiatrist and researcher at the University Health Network in Toronto, as well as the University of Toronto. And a lot of my work is clinical, and so I take inspiration from a lot of the patients that I see, and I also do research around the topic of suicide, especially in Muslim populations. I don't have any financial disclosures to disclose. However, I will just note that I'm speaking today as a suicide researcher and a clinician, a psychiatrist. I am not a religious scholar, and as you know, this topic does carry with it theological implications. And so, finding the appropriate resources for that is important. But I'm happy to answer any questions related to sort of the clinical aspects of this topic. Again, just a reminder that some of these topics can be emotionally quite heavy. Even if you're in healthcare, I know many of us have had experiences of loved ones and may have also had experiences with suicidal thoughts or behaviors. And so please make sure that you're taking care of yourself, and if you need to reach out, that you're able to do so. Here are some resources for that. So my objectives for this presentation today is to equip the people here with information about the risk factors and protective factors for suicide in general, and then within Muslim communities as well. Really drive home the importance of incorporating religious and spiritual approaches when treating patients who have suicidal ideation. An approach to safety assessments when working with people who are experiencing suicidality, and also thinking about communally, how do we respond to these tragic events? I like to always start off with a case. It really helps us sort of hang on some of these principles to examples. As we're going through the presentation, I encourage you to think back about this case and how you would apply some of the principles that we're discussing to this case. This is not a real person. It's themes that I have sort of derived working from different people who have had these experiences. So let's think about a Muslim young woman, Sarah, 18-year-old, finishing high school. She is currently living with her parents and two siblings. And really, her anxiety has been very problematic for a few months, with panic attacks emerging several months ago. So she describes this as very intense anxiety, feeling suffocated, breathing hard. She tells you that there is bullying at school around her Muslim identity. She wears the hijab, she's visibly Muslim, and she's been feeling excluded and discriminated against regarding this. And she discloses to her family physician that she has been self-harming by cutting herself on the arms, and that she's also had sometimes the urge to just end it. So this kind of presentation, this kind of person, these struggles, as you know, can be very, very prevalent for anyone from family physicians to mental health therapists to psychiatrists to counselors. We all who are working in this field have been seeing very, very similar struggles. So I'll try to give you a general context around the topic of suicide in Canada. So as we know, suicide is one of the leading causes of premature death in Canada. 4,000 people die by suicide every year. It makes it a relatively rare attempt, however, rare event. However, for every person who dies by suicide, we estimate that there are at least 25 to 30 people who attempt. And so the suffering associated with this can be quite widespread. We also know that 90% of people who die by suicide have a mental illness across North America, and we see that pattern in other countries as well. So, for example, a study in Karachi, Pakistan noted that 96% of suicide deaths were associated with a mental illness. I really like to remind healthcare professionals that suicide is a multifactorial phenomenon. There are so many different vulnerabilities and reasons and drivers for suicide that we can never try to be too simplistic in our thinking and try to reduce it to one thing. So, for example, we really discourage people from trying to, if they hear about a suicide, to make simplistic sort of judgments around that, saying this happened to this person, that's why they died by suicide. It's really about many, many different factors coming together. I've listed some of them here, and we'll go over a few as well. In terms of the risk factors for suicide, factors that make someone very vulnerable to suicide, the most significant one is having a history of deliberate self-harm or suicide attempts. The more recent the suicide attempt, the greater their risk of further suicide attempts as well. That's the most significant one that comes up. We also know that males are at greater risk than females. There is some variation by geography, but definitely in Canada, the ratio is approximately 3 to 1. Mental illness, like I mentioned, is a major factor. Age is important to consider, so that 45 to 60 age range, and then 80 plus, the suicide risk goes up again. Isolation and lack of social supports, that's major. People who are very isolated don't have community connections, interpersonal connections can be at quite high risk. And then substance use as well. And one of the major reasons we think this happens is it decreases people's inhibition, their natural instinct to protect themselves, and therefore can make them more vulnerable to acting on their impulses. So this is just a visual demonstration of what we were talking about, males being at quite greater risk of completed suicide, and that age range of 40 to 60 as being quite vulnerable as well. I often find clinicians tell me they're surprised by this because they often get told the older you are, the greater the risk. But Canadian data does indicate that the rates are quite high between the middle age to older men. In terms of protective factors, there are several that are important to consider, and I often find that we think a lot about risk factors, but not enough about protective factors. So, having problem-solving skills, positive peer relationships, community are all protective, as well as cultural or religious beliefs about suicide, but also community, and we'll get more into that. I introduced these few slides here this year. So I did this presentation last year with a focus on suicide, and I got feedback that while that's very helpful, a major struggle that people are seeing in clinical practice is self-harm, and many clinicians not being sure about how to approach it. So I really did want to just make a quick note about this and acknowledge the prevalence. So there are similarities and differences between self-harm and suicide. It's important to acknowledge both the similarities and differences and not conflate the two. What I will say is that both indicate that there is high distress and suffering going on for the person, and both need to be taken seriously. A lot of people, especially young people, will tell me that their self-injury is not done with the intent to end their life. So sometimes there are other reasons, which we'll get into, for why people are self-harming, and that their intent is not to end their life. So if we think about this as sort of a continuum, people can have low intent to die and they'll be injuring themselves, and that's where we think of self-harm. But the problem is that sometimes self-harm can lead into unintentional suicide, so unintentional death. Whereas other people, their intent is very clear. Their intent is to end their life. Self-harm rates in the 2010 to 2015 period, we were noting a rise. They had stabilized somewhat, and we're waiting for the newest data, especially out of the pandemic as well. But as you can see, the majority of people who self-harm are girls, and it's the really adolescent period where people are at greatest risk for this. Now, there was a study done in BC where they actually asked young people directly why they were self-harming, and the most common response was there was something about it which they were using to calm themselves down. Other people said punishing themselves or to stop feeling numb. I think the key message should be it's really, really important for the clinician to ask the patient directly in front of them why they're self-harming and what it does for them, and try to do so in a non-judgmental and open way, so that we can work together with the young person about alternative approaches. So the topic of religion and suicide is a really interesting one. For decades in our field, in suicide research, religiousness and religious attendance was associated with a lower risk of suicide across studies. So for example, I'll give you an example of a systematic review where out of 68 studies, 57 noted a decrease in suicide rates in those people who were identifying as religious. However, what I will say is in these studies, religious affiliation can be quite broad and contextual, so we have to consider specific factors. In Muslim majority countries, generally, there has been in terms of the rates of suicide, they have been lower compared to non-Muslim or Muslim minority countries. What I will say, however, is within the database and within the research community, there is also some question about how reliable the rates are out of some of the Muslim majority countries. As many of you know, suicide is considered illegal and there are penalties in certain Muslim majority countries, and that might skew how deaths are reported. So there is some question around that. That being said, in terms of global data that is reported by the countries themselves, we see a lower suicide rate. When they actually look at the risk factors for suicide, many of the same risk factors that we talked about earlier come up here as well. So psychiatric disorder, and I apologize if this is small for you to read, but psychiatric disorder comes up over and over again, past attempt, trauma, isolation. These are some of the common across communities risk factors that keep coming up. If we think about religious affiliation as being protective, the question is, how does it protect? Why is it protective for suicide, theoretically? One theory is that there are specific doctrines that prohibit. So, for example, Abrahamic religions, there is a clear prohibition around suicide. And so there's a theory that because these prohibitions are so strong, that's what deters people from suicide. Another theory is that religion can give people a sense of purpose and meaning. So when they are going through difficult life events, when they are having a really hard time, religion can give a framework for understanding why these things are happening and something to look forward to. So for example, Islamically, there are people who believe that, having this hardship can absolve them from sins. And so it gives this way of interpreting what is going on with them that can bring them comfort. And then a major one is the idea of religious attendance. So being tied into some sort of community can be really, really helpful and can give people a sense of social support, social cohesion that can be protective as well. As you can imagine, these factors are very, very hard to tease apart. So it's hard for us to know which of these is the most significant in possibly conferring the protection from suicide. Now, the big question that obviously arises is that, is religion still protective if the religious group is a minority group that's facing discrimination? So, for example, Muslim communities in North America and Europe, they might still have some of the protective effects, which is those doctrines, that sense of purpose and meaning, and community. But there's that added layer of isolation, discrimination, and marginalization that may compound other sources of distress. For those of you who attended the talk in the morning, Dr. Rania Awad is really one of the blessings for our community and is doing some of the groundbreaking work around this. And she and her team published this research letter in JAMA Psychiatry showing that Muslims, compared to other faith groups, were more likely to report a previous lifetime history of a suicide attempt. So this was quite concerning, and it definitely warrants further exploration as to what is going on and what is making this community vulnerable. So specifically thinking about Islam and suicide, like I mentioned, similar to other Abrahamic religions, suicide and deliberate self-harm are considered to be prohibited acts according to mainstream Islamic teachings. There is a growing body of work, and thankfully with people who have expertise both in religious tradition and psychiatric issues. And there is complexity on the idea of who is accountable for actions of suicide. So this idea of who is considered to be of sound mind. And so followers, so people who are not scholars, or we're encouraged to leave judgment up to God, and as none of us can be aware of what is happening in the hearts and minds of a specific individual when they're going through something like this. As we know, Stigma is a major issue. So people who do identify as Muslim, who are religious, can feel a source of spiritual or religious guilt and shame if they are experiencing suicidal thoughts or if they have had an attempt. And this can prevent people from reaching out as well. I hear this all the time from young people that I have worked with. They're very worried about reaching out for help, whether from their families or religious communities or mental health clinicians, because they're worried about the judgment and the stigma that they're going to face. Families of people who experience suicidal thoughts or people who have actually died by suicide can experience also exclusion and ostracization, and this can be a really difficult time for them. And then I would say there used to be, and thankfully I'm not seeing this as much, this belief that talking about suicide can cause suicidal thinking. I capitalize this, it's not true. Data has proven this time and time again. So you can ask about suicide without being concerned that that's going to trigger other people to think about suicide or cause suicidal thinking in them. Most often, a person, when they're asked about suicidal thoughts and if they're experiencing it, just feels such a sense of relief at being able to tell someone else what they're going through. A really important reminder is that thoughts are not the same thing as actions, which is a religious principle in Islam. And one of the Quranic ayahs that I love around this topic is about our beloved Maryam. May the peace and blessings of Allah be upon her. And the story of her giving birth is being told. And in this ayah, this translation reads, "The pains of childbirth drove her to the trunk of a palm tree. She said, 'Oh, I wish I had died before this and was in oblivion, forgotten.' But he called her from below her, 'Do not grieve. Your Lord has provided beneath you a stream.'" And so this idea that people who are extremely religious and pious can reach points in their life where the distress and the suffering they're experiencing may even lead to some wishes for death. That does not make them an evil or sinful person, because thoughts do not equate to actions. So the message here is that many people, including really pious, religiously grounded people, can experience thoughts, but the vast majority do not act on them. But thoughts can be an indication that more help is needed, that more support is needed, and it should be a trigger for that person or the family to try and reach out for some greater support. What are the implications for clinicians? Why is asking about religion important in suicide prevention? And I think this is a really important question for many people who are working in healthcare, because sometimes there can be this belief that medical settings or psychiatric settings, mental health settings, need to be these sterilized versions where we can't talk about this. Sometimes clinicians also tell me that they get worried if they ask patients. The patients will feel like the clinician's beliefs are being imposed onto them. This is not the case, and I will go through some ways that clinicians can ask these questions. But just reminding us that if we don't ask about religion and spirituality, we may be missing an important protective factor against suicide. Also, if patients feel like this part of their identity is not being seen or recognized, then they may have trouble building a trusting relationship with the healthcare provider. And then it also can impact how likely patients are to adhere to clinicians' recommendations. Just a very brief anecdotal example. I spoke to a psychiatrist at a conference who was practicing in Pakistan, and she was having significant difficulty with patients not really adhering to treatments. And she piloted this really amazing model where within the same clinic, people were able to see a psychiatrist and also a sheikh or an imam, and carry through with both recommendations. And that actually increased the adherence of patients in terms of medical treatments, biological treatments as well. So really, acknowledging that person's religious, cultural beliefs can be such an important tool for helping them engage in treatment. A note about therapeutic alliance. So this is the relationship between a healthcare provider and a patient. And I will say, maybe even for anyone who's providing support, it's the idea that relationships can be life-saving. I talk to a lot of people, adults and young people, about suicidality, about having gone through this experience in their lives. And they tell me that a single relationship where they experience kindness, compassion, lack of judgment was so transformative for them. And so I remind all of us, sometimes we may minimize our own roles as healthcare providers, but if we can create compassionate, safe relationships, those can inherently have a lot of therapeutic benefit for people. I always remind clinicians that it's okay to have your own beliefs about things like suicide or self-harm, but you have to refrain from judgment and harsh attitudes within the clinical settings, because that will drive people away. Try to really listen to what the person is telling you and why they're experiencing what they're experiencing. In terms of general strategies, I encourage everyone to ask openly about suicidal ideation, suicidal intent or plan, any preparatory behaviors that people might have engaged in, and whether they're engaging in self-harm or self-injury. So, something as direct as, have you had any thoughts about ending your life? That's a simple question. People are welcome to say yes or no to that. If they say yes, then that's an indication that you want to go further with the exploration. Open-ended questions are great to start off with, and then you can start getting more specific. So I might say something like, tell me more about those thoughts. When do those thoughts come up? And what do you do with those thoughts? Have you taken any actions to follow through? Have you gone on the internet and researched any methods, right? So these are important to get into sort of the nitty-gritty, because it will help you determine next steps about this person. And make sure that you're reviewing risk factors and also protective factors. So protective factors are really important. I laid them out, but you can ask people directly, what helps you keep going? Why haven't you acted on these thoughts so far? And I love that question, because the answers that people give to that are often a demonstration of their spirituality, of their resilience, of their love for their family, for example. So clinicians do ask me, how do I broach this topic? Because it feels awkward. I don't want to impose any of my beliefs onto the patient. And so the DSM-5 actually gives us some helpful terminology around this. And Dr. Awad mentioned some of these examples as well. So for example, an open question like, do you identify with any particular religious tradition? Can you tell me more about that? And this is a question I ask often. What role does the religion play in your life? What role does Islam play in your life, for example? And that allows people to say it's not very important in my life right now, or that it's the most important thing in my life. It's acknowledging that people are at different stages of their relationship with religion. And this is really important. Have you experienced any personal challenges or distress in relation to your religious identity. Now, that one's a bit of a mouthful, so you can kind of reword that in a way that makes sense. But essentially, having a religious identity can be helpful, but sometimes it's hard. Sometimes people face discrimination because of their religious identity, and sometimes they may even feel a sense of exclusion and lack of belonging in their religious communities as well. So you want to also open up the space for them to tell you that. In terms of suicide scales or questionnaires, they can be one way to supplement your assessment, but I encourage you not to use them as your full assessment. So some of the examples of scales that I've used are, for example, the Columbia Suicide Scale or an Osler Suicide Interview Checklist. Again, I always add that caveat. This is not a matter of handing someone a piece of paper so they can kind of check things off. However, it's a way of helping you make sure that you're being comprehensive and thorough so you can use them as part of your assessment. So a really, really big message that I want people to walk away with is that for decades, we have researched the research community has been looking at suicide, looking at the risk factors and protective factors. And after all of that, we cannot accurately predict suicide. I think it fits well, actually, with the Islamic worldview that Allah is the knower of all things, especially the hearts and minds of people. And so you cannot take it upon yourself to be able to accurately predict suicide because we simply cannot do that. However, what we can do is we can bring together risk factors and protective factors. We can summarize them in a way that helps us guide what we do next. And I'll try to demonstrate that by using these principles for the case that we looked at earlier. Now, the next couple of slides are quite text heavy, so I do apologize for that. But clinicians will often ask me, how do I find the language to document and to capture all of this? So this is the system that I use. This is Dr. Zahir has summarized these here, and she's a leading expert in suicide prevention. So if we think about risk status, we're really thinking about in the acute situation, imminently, how do we assess a person's risk, knowing all of the inaccuracies around this. So for example, if someone has had no recent suicidal ideation and no history of suicide-related behaviors, you can say their risk is not acutely elevated. And there's a certain management for that. For example, you can continue outpatient management. You don't have to be super close, for example, in terms of monitoring their safety. However, let's say someone has current suicidal ideation, but they don't have intent or plan. They have some warning signs, but they also have some protective factors. We would consider that a moderate acute risk. And then similes, these are now more high acute risk, someone who is repeatedly thinking about suicide. They have a plan, they have active psychiatric symptoms, their substance use on board, for example, this person we would consider to be at high acute risk. I am aware of the time, and as always, I'm running behind, so I'll try to speed up, but happy to answer questions later as well. So one of the tools that I find really helpful in working with clients who are experiencing suicidal thoughts is what we call a safety plan. So these are for people who you're going to continue to work with as an outpatient. And it's a tool to kind of help the person develop some strategies about keeping themselves safe. So it really does require collaboration from the client. So let's go back to our case. Sarah, like we said, she is finishing high school. She's being bullied. There's a lot of anxiety recently, and she's told her clinician that she's self-harming, but does say that in terms of suicide, she has the urge sometimes, but she says, I would never do it. Some things to think about in this case is that rates of completed suicide are low among this population, so do not panic as a clinician. I mean, you should never panic as a clinician, but something to think about. Non-suicidal self-injury or self-harm, like we talked about, can be quite high in this age group. You really want to try to understand the motivation, right? So you want to ask, like, what is causing this? What is happening for you? And like I say, paying attention to the protective factors, and whether she's interested in culturally specific care. Now, the idea of involving family is complex. Ideally, it's always great to be using families to support patients. However, there are times where the patient is insistent on confidentiality. And if you don't have, for example, an acute safety concern, you wouldn't be allowed to breach the patient's confidentiality. So that part can become quite tricky. And completing a safety plan. So an example of how I would put together my risk assessment is this. I'll say Sarah has no history of suicide attempts. She is experiencing suicidal ideation with no intent. She is engaging in self-harm, which shows high distress and difficulty with impulse control. Acute stressors are recent heightening of anxiety and bullying at school, and protective factors are religious beliefs, friends, and lack of substance use. Overall, her acute risk is moderate. Medically speaking as well, this helps demonstrate that you are thinking of all of these factors. And like I said, my main goal always is to use the suicide risk assessment as a way to target treatment. So that assessment, I will then use to say, okay, my priority is I want to complete a safety plan that helps keep Sarah safe. I want to connect her with mental health supports and try to decrease anxiety using biopsychosocial and spiritual modalities, because anxiety was identified as one of the main drivers of her suicidal thinking. Remember that one of the drivers of her suicidal thinking was also the bullying that she was experiencing at school. So we can't ignore that. And one thing would be considering like involving the school. And also helping her develop alternative coping strategies so that self-harming does not feel like the only option that she has to cope with the stress. So in terms of resources around self-harm, I found these helpful, the Calm Harm app. And then there's a website called Self-Injury Outreach and Support that gives people alternatives or methods to avoid self-harming and alternative strategies. So for example, if I was working with Sarah and I was making this safety plan with her, and remember it is with her, we can't just fill it out and give it to her. I'll ask her, what are some warning signs that I may not be safe, that you may not be safe, and we'll fill these out. For example, if she starts having repeated and persistent thoughts about dying, researching ways to end my life, thoughts about self-harming, these are warning signs. Reminders of reasons for living. And again, these are all from various people that I have actually worked with. They might say like certain ayahs or hadith are helpful, family, friends. What are some coping strategies that can be used in the moment when people are having these really difficult thoughts or urges? So going for a walk, taking a warm shower, listening to calming music. Again, this might be what people have already thought about, but it really does help to have them on paper in an easily accessible location. When people are not feeling so much in control of their actions, having these reminders can be helpful. Social situations and people that can help distract me in the moment. So for example, Sarah might say, calling Amina, going to an event, and people who I can ask for help. So if things get bad and I need support, parents, Nasiha Distress Line or Gerstein Crisis Center will be, for example, so resources that Zara reaches out to. I know this is quite hefty. I will go quickly through the next part and then we will get into sort of the Q&A. I just wanted to make sure that we talk about the idea of community and how we respond to suicide when a suicide does occur in the community. So the idea of contagion is a well-documented in research phenomenon. So if there's a suicide in a community, suicide rates tend to go up. So that means it's necessary and life-saving to have thoughtful and evidence-based responses to suicide deaths in the community. And again, Dr. Awad has written about some strategies, which is not to make judgments about the deceased, not to share details about the death or suicide notes, like the contents of this, and not sensationalizing or romanticizing or trying to rationalize the person's suicide. What you can do is check in with each other, making sure that there are safe, comfortable spaces for people to share their reactions and emotions, and sharing resources and encouragement to seek out support. Now, there is some work being done in this field. So myself and a team of researchers were looking at suicide and self-harm among young Muslims in the GTA. So inshallah, next year, there will be some data around that to share. There is ongoing groundbreaking work from the Muslim Mental Health Lab at Stanford, led by Dr. Awad, and training for imams and religious leaders when they encounter Muslims with suicidal thinking or behaviors. The very last note that I will make is that one of the main motivations for me personally to work in this field is that the clients and patients that I work with are just incredible. When they have suicidal thoughts and behaviors, it's a really, really low point in their lives, but they also demonstrate such resilience and strength. And often people are really eager to hold on to their religious traditions and coping strategies during this difficult time. So inshallah, as we continue to research this field and develop resources, we can make space for people who want to really bring in their religious identity, because it's so important to them. And then again, just reminding people, please take care of yourself. And if you're feeling like you need help, to make sure you reach out. And I will pause there.
Thank you so much, Jazakallah khair, Dr. Furqan. That was super comprehensive and very nuanced. I'm really appreciated hearing those things from you and things for me to keep in mind. We've got several questions, so I'll just kind of go through them as they came up. So somebody is asking, they mentioned that it can be seen as unethical to impose your own religious beliefs on clients. And then they're mentioning that, they appreciate that self-harm is prohibited in Islam, and they feel they have a duty to help and advise fellow humanity to help avoid things that are prohibited. And what's your advice regarding the duty of Muslim clinicians to help their clients, whether they're Muslim or not, to decrease in how often they engage in self-harm, especially if it's something that they see as a coping mechanism and they don't necessarily plan on ending their life?
That's a really, really excellent question, and it's something that I think Muslim clinicians do struggle with quite a bit. So I'll tell you about the approaches that I've taken, which is that in my experience, it's really, really important for the clinical space with the mental health clinician to be one that is safe, and that takes precedence over anything else. So in that case, the clinician would be encouraged not to share their own sort of judgment about a particular behavior. That being said, we are obviously acknowledging the intersections of religion and mental health and spirituality. So I would say an ideal situation might be asking the patient if they are interested in incorporating religious frameworks or religious leaders in their treatment. So I've worked with several patients on inpatients and outpatients who I asked that question, and they did ask for a chaplain or an imam to be involved. And that way, if they were looking for spiritual or religious guidance, they are able to get that as well. And they can also use me for the mental health or clinical aspect of things.
Thank you very much. I hope that answers the question. Oh, that answered it for me. I hope it answered it for the other person. So another question, this person is wondering, if a low or moderate risk individual doesn't receive help, what is their likelihood of becoming a high-risk individual for attempting or completing suicide?
Again, it's a really, really good question. And I think it's a good point to also just emphasize that being a low to moderate risk, like someone whose risk you're classifying as low to moderate, does not mean that they don't need help. Someone can be in a lot of suffering and a lot of distress, and they need a lot of help and still, for example, be classified as low to moderate risk. So you want to make sure that you are offering everyone the appropriate supports. It's just that what those supports look like might be different for someone who is who you're classifying as low risk. So for example, if I saw someone who I was classifying as low to moderate risk, I would still be offering them treatment. I would still be giving them follow-up. I would still be providing care, but I might not be considering, for example, an inpatient admission or an immediate visit to the emergency department. Whereas someone with that I might classify as high acute risk, I might say, you really aren't safe at home, and we need to go to the emerge. I might even need to walk them down to the emerge, right? So it's about using that to guide what your next steps are, but everyone should be receiving care and support.
Absolutely. So this next question, they're saying parents can sometimes play a role in neglecting signs of self-harm and suicidality, especially in families with certain ethnic backgrounds where mental health and suicide is stigmatized or misunderstood. So would you be able to speak to the impact of this on children, and also how, I guess, from a clinician point of view, how you can increase mental health awareness among parents who kind of share these beliefs?
Yeah, so I've encountered this quite a bit. Even though I'm not a child psychiatrist, I often work with young people and their families. And the person who posed the question is quite right, that often self-harm or suicide might be ignored or neglected within the household. And often where that's coming from is a lot of discomfort within parental figures or families about not knowing how to talk about this, not knowing how to help. So it's sort of like, if we pretend we don't see it, then we don't have to deal with it, which obviously makes the suffering and distress for the child or the young person worse, right? So I think at a community level, we need to be raising awareness about these topics. So at masjids, at khutbahs, at community circles, so much of what's needed is education, but also attempts to shift attitudes. For example, I hope that information like how prevalent mental illness is in people who die by suicide can help people and families think, okay, maybe if we try to support the mental illness, that we can help with the suicidal thoughts or the self-harming behaviors as well. So there are some certain grassroots kind of approaches in education and awareness that needs to happen as well.
Thank you for that. So another person's asking, what role can, or if there's any evidence that exists about allied health professionals, so like occupational therapy, what role they can play in engaging individuals in religious practices to promote those protective factors. They spoke a bit about collaborating with community leaders like imams. I guess this person's wondering what role can allied health play?
Yeah, I think so much is sort of the short answer. I think in my work, I rely on my allied health colleagues a lot in clinical settings, but also this person is saying that on a communal level, sometimes the medical community and within the psychiatric field, we kind of do end up focusing a lot on biological treatments and sort of jargon as well. So finding ways to communicate with communities about biological, psychological, and spiritual approaches, I definitely think that allied health can play a role as well.
Sounds good. Thank you. There is one question. I don't know if you may know the answer to this or part of our organizing team might respond, asking about if there's any specific imams or sheikhs in the GTA that you're aware of that are comfortable providing guidance in mental health. So speaking with students, that sort of thing.
I think earlier on in the resource fair, it was mentioned, like some of the resources were mentioned. So I would encourage participants to look at that. And if someone could post the website as well with the conference details as well as the resources, that would be great. I think it's Muslim Meds. I can't remember the exact URL. The other place, Muslim Chaplaincy at U of T, has been great as well. Great. Dr. Malik just posted the link for that as well. There is a question on the chat as well.
Yes, go ahead.
Yes, I think that's a really, really important question. And I do agree with the person asking the question, which is that for younger people, involving parents can be necessary, absolutely, to help keep them safe. And so I think one of the really important parts is before starting the assessment, to be really upfront with young people about this limitation on confidentiality, which is that we can respect your confidentiality to a certain degree. If we get worried about your safety, then we may have to involve your family to ensure that you are safe. And so the person posing that question is right. Like it can be a matter of keeping them safe, and we may need to break confidentiality in those cases.
Sounds fair to me. So I don't see any further questions in the Q&A. We can give it a minute or two. But otherwise, thank you so much, Dr. Furqan. That was, as a learner, that was like super informative. Very, very grateful to be able to learn from you and everybody else today. Let's see. Oh, there is a question about, I guess, more of the elderly population, so it says elderly failure to thrive issues. Maybe I'm wondering if this is like in the context of neglect, perhaps, or elderly failing to cope. You did speak to suicide risk increasing across the lifespan. So like in youth and then elder adults, if maybe you could speak a little bit more to that.
Yeah, if someone's interested in this topic, a colleague of mine recently published a paper. So I'll try to post the link here, but essentially they looked at suicide notes from people who were elderly and what motivated their suicidal thinking. And, severe medical illness, limiting their independence, for example, can be a major factor. If they're isolated and if their spouse has died, all of these are contributing factors to a person's suicidal thinking and behaviors. And so it is important to consider those and ask about those as well in that population. And try to connect them with supports that are appropriate.
Thank you very much. So I think we'll say we'll wrap up our Q&A there. Thank you so much once again, Dr. Furqan. For the rest of our attendees, we're about to go into another prayer break. So for Asr, and then during that time, there will also be a lot of people ask questions about like resources. So there's going to be that resource fair going, and then you can just take a look at those resources there. Then it'll also be on our website.